Everybody, and a Happy New Year. I'm Dr. David Gross, psychiatrist.
And Happy New Year as well. I'm Dr. Andrew Rosen, psychologist, and welcome to Two Shrinks and a Mic.
Today we're going to talk about a variety of topics, mostly related to the issue of what kind of treatment to choose and how long to stay in treatment. And these are all issues that are kind of fuzzy in general for most of the individuals we meet with. And they're very important because it's easy to get started with the wrong kind of treatment, and it's easy to oftentimes stay in treatment longer than is necessary. So we're going to be talking about both medication treatment as well as the psychotherapies.
Yeah, it's really, for the average person, it's a complete unknown territory, both in terms of who to go to, which we talked a little bit about before, and what to expect, and how long does one go for? Is this, what we're used to when we go to the doctor for, maybe one or two visits to get an antibiotic or to check an x-ray? But this is a territory that really nobody's familiar with, and it is very unique and very different. So first step would be to discuss a little bit about the different types of treatment, which we've touched on a little bit before, but let's go first into that, and then we can talk about, if you do go to a particular type of treatment, what to expect in terms of frequency, duration, when to expect some positive results.
And in general, the approach to treatment has to rely upon a very good comprehensive evaluation. And the evaluation needs to determine how much of the individual's difficulties are due to life situation, because oftentimes it's stuff in life that gets the best of us, and there the treatment is a bit more straightforward in terms of identifying the issues in life that can be addressed and the issues in life that can't, and how a person can cope better with the good, the bad, the ugly of day-to-day life. Part of the evaluation also has to evaluate whether or not this has become an ongoing biological, medical disorder. There are individuals under stress, for example, who have persistent symptoms way beyond the period of time that the symptoms should have ended. You can take as an example the loss of a close loved one, a parent, where going through the grief cycle, the mourning period, is no different than what we now call major depressive episode. People can't sleep, they're not happy, they're crying, they're at times hopeless, feeling stuck, negative thoughts, never going to change. But for the most part, that's a time-limited experience. Time-limited because the trauma to the brain of the loss, which is biological, although we've yet been able to measure it, is time-limited. The brain learns how to compensate, and eventually, after a period of time, the symptoms of mourning and grief begin to subside. When it lasts longer than it should, then we get concerned about what's called pathological grief reaction, where the biological changes have persisted, and there's a need to address it more aggressively with medication. And so evaluating the situational versus the biological aspects of what the individual comes in with is most critical.
And that's a good example of, for the person who is thinking of getting help, to decide, is the issue one where I'm really in pain, I'm having symptoms, I'm hurting, I'm having a tough time, and I desperately need to get some help with this? Or is it a situation that many people find themselves in where they're not in any particular pain, they're not having any particular type of symptoms, but they realize life is complicated, maybe they just need somebody to talk to get some clarity about some issues that they're dealing with, or they just feel they need to get things off their chest, or they just feel like, life is so complicated sometimes that it's good to talk with somebody else and sort of brainstorm, if you will, some of the confusions that can exist in life, or some of the times of life that are complicated and need some extra time to talk about and explore. So that could be a dividing line. If you're having symptoms, if you're really hurting, if you're really in need of extra help from a mental health professional, that will be one pathway and will have its own, sometimes more clear guidelines in terms of who to go to and typically how long that treatment might take. if it's more the second type I was discussing, where it's, I think I need somebody to talk to about life, well, that can be short term. It could be a quick problem solving scenario, or it can go on for months and sometimes years, where the mental health professional is more like a life consultant in helping get through different stages of life. And some people describe it as, it feels like I have a friend, but it really isn't. It's very focused on helping a person have clarity about what's going on in their life.
You know, one of the challenges for both of us is the quandary that most individuals have when they come to see us. Very commonly, somebody will walk into my office, and I'm sure you've had the same experience, where they'll say, gee, I don't know what's wrong with me. I just feel terrible. I don't know where to start. And they're anxious to begin with, meeting with a stranger, talking about personal issues, somebody they've never met before and not sure they could trust yet. So our job is to help them clarify as specifically and as objectively as possible what they're describing. And I tell individuals, and I've said this before in our podcast, that unlike other areas of medicine, we cannot send people for regular blood tests, x-rays, and objective tests. We have to rely upon subjective report, language, words. So I ask people to try to tell me as clearly as possible what they're experiencing, and I'll frequently, in the course of listening, try to clarify and get a better understanding of what they mean by I'm depressed. Because people oftentimes will say I'm depressed when in fact they're not, and they're not experiencing depression, but they could be experiencing anxiety. And the opposite is true as well, where people come in and say, gee, I'm anxious all the time. And then when I ask them to describe it, you begin to hear that there are signs of sad mood and depression, and there have been life events that have triggered it. So our job is to, like a detective, tease out the specifics of what that individual is experiencing, to highlight both what their life is like, what the world around them is like, whether it be their family, their job, their experience at school, friends, and what's it like internally to experience what you're telling me, that you say when you come into the office, I feel crummy, doc, you got to help me. Well, I'm happy to help you, but we've got to figure it out first. And once we figure it out, then we can put together a treatment plan.
And the person who's in a good deal of pain with symptoms is actually, in some respects, in a better position in terms of recovery than the person who's not in a lot of pain, and maybe some of the, you can't even describe them as symptoms, it's just a kind of an unfulfilled, maybe unhappy life. And those are more complicated and will take longer to figure out and come up with solutions. The person who's in a lot of pain, let's say with depression or anxiety, it is easier to see it, and it's more palpable. And the kinds of treatment modalities that we have to help with symptom resolution are pretty clear and mostly short term. So if a person is really suffering, when they come in, we can pretty much figure that in most cases, within a couple of months, they should be feeling much better, whether it be because of medication and or the type of therapy that they might be engaged in. The person who's not in any pain really, but just confused about what to expect out of life and maybe have some decisions to make about the future and what they would like to have in their life and who they'd like to have in their life, more complicated, and they do take longer. So when we look at the question that comes up about, well, how long does one go to a mental health professional? There's no one answer for that. There's no one size fits all. It really depends on why you're coming, the severity, and what the expectations are. I sometimes look at it like this with an analogy or a metaphor. If somebody comes in a lot of pain, I describe that as the glaciers of the Alps, the highest peaks of the Alps. And if somebody comes in with a moderate amount of pain, well, they're in the Alps still, they're high up in the mountains, but not quite at the tippy top. Our goal, regardless, is to get people to come down to the foothills so that they're participating in life with the normal difficulties and stressors and upsets and obstacles that people will have inevitably, but they're down in the foothills. They're not in the high mountains, and they're certainly not in the peaks. Our goal is to get them lower and lower. The higher up they are when they come in, the quicker we can get them down.
You know, there's then the challenge of the individual who shows up on our doorstep in our office and says, when we ask them, what can we do to be of help, or why are you coming to see me, they'll say, I have no idea. My mother told me to come, or my spouse told me to come, or the boss told me I needed to get help. And the difficulty there is that these are individuals who may not have a sense of a problem. They may not be in the emotional pain that other people observe. So there's a different challenge for both of us. There, the challenge is being able to establish more of a relationship of trust where over time that individual can open up and really talk about what's going on. Because you know right from the start that this individual may not be that motivated to get better, and certainly isn't motivated to give us as good a history as we need to figure out what's going on. Oftentimes, if somebody comes in with a parent, for example, or a spouse, and they're not sure why they're there other than they came because they were told to come, with their permission, I will ask that the loved one or friend, for example, to come in and join them for the initial part of the evaluation so I can hear from them what's going on, and the individual who comes in for help can hear once again what people are observing, so that we can break through some of the lack of understanding and the lack of insight that the individual has in the first place. But establishing that initial trust, that it's okay to tell us what's going on, that we're not going to think negatively of you or criticize you or ridicule you or anything like that. That's the first challenge in any office visit. And I will honestly ask people when they walk in my door, how can I be of help? Because it opens the door to the fact that things can get better, that there is a chance of forward progress. And that belief in, as we talked before at previous podcasts, hope is critical in the beginning stages of treatment and becomes critical as treatment proceeds.
Unfortunately, the person that you described a few minutes ago who may be coming out of compliance or out of fear of some consequence, they're the most difficult patient to engage, and they tend to not come for very long. Very often in their minds, they're coming just to placate or satisfy some requirement or some expectation or some current complaint. And they really don't necessarily feel any symptoms. They don't really feel any pain other than the feeling of being badgered or bothered by the person who's asking them or demanding that they come for therapy. So that's not the best prognosis person. The best prognosis person is the person who's either A, in a lot of pain, or B, realizing that they do need somebody to talk with, and there's no shame or embarrassment about that. I always say, look, we have consultants and experts for just about everything we go through in life. We have lawyers, we have accountants, we have plumbers, we have all kinds of people to guide our financial portfolios and on, or the service advisor at the car dealership. The most simple things, but for the most complicated thing that there is in the world, which is living, we shy away from having somebody who may sit with us and figure things out and come up with some better plans in terms of how to manage life. So the person who's in pain and the person who's savvy enough to know it would probably be a good idea to get somebody to talk with, those are your best candidates. In terms of the kinds of treatment that we have available, well, we've talked a little bit about in a couple of previous sessions about psychopharmacology, and maybe you want to mention some of that, Dave, before we move on to the other types of treatments.
Sure. Well, once the decision's made that there is a significant biological component, what I explain to individuals is that this state, because of the shift in brain chemistry, it can be persistent, and we can address it biologically with medication. I try to help people understand that medicines are not a silver bullet. That if somebody, as you've mentioned, is dealing with life-related issues and situations in life that are causing lots of grief, but it's gotten them into such a dark hole that the medication can help show people how they can move forward and then proceed with psychotherapy. That it gives them a leg up. It gives them a chance to proceed with psychotherapy. And for the most part, if we recognize that there's a depressive disorder, antidepressants can make a big difference. People tend to see antidepressants as all being the same, and they're not. I mean, the major class are the selective serotonin reuptake inhibitors, like Prozac and Zoloft and Lexapro and Celexa and Paxil, et cetera. But they're all slightly different. And oftentimes I'll pick medications based upon lack of significant side effects and my experience with how effective they can be. But I let people know that this is a medication that will not change your personality, will not turn you into a different person, but will address specifically the symptoms that we're working with. And that's why I tell people that we need to isolate what the target symptoms are. Let's list 3 to 5 of the core symptoms, like lack of energy, overthinking, not sleeping, poor appetite, lack of pleasure, because it's very helpful to pay attention to that. I mean, if you go to your internist because of high blood pressure and get a high blood pressure medication, they're going to be using the objective numbers in the blood pressure cuff to determine whether or not this is the best dosage of medication or the best medication for you. We don't have that. So I have to rely upon what really has gotten better and what still needs to get better as the trial of medication proceeds. I tend to start at a low dose. I think it's easier for people to tolerate medications and also helps people get over their initial anxiety about medication, because for people who are naive to psychiatric medications, it's a scary notion. People think that it must mean I'm really very, very sick. I must be a crazy person, which it doesn't mean that at all. And so if I can have them experience the medication at a low dose and find that they can take it and not have any side effects, then it makes it easier for me to get them up to a therapeutic dose, which is a dosage that will then begin to help them recover.
Dave, for the person out there who might not know much about medicine but thinking about it, are there any guidelines in terms of how long they might need to be on a medicine before they experience some help with their symptoms?
Well, basically, if this is a person's first experience, for example, with depression, then we recommend a 6 to 12 month trial after feeling better. And the rationale for that is that research has demonstrated that if these antidepressants are stopped too soon, even if someone's been feeling well for a month, there can be a relapse. We don't really understand why. My bet is it has to do with the fact that the chemical imbalance in the brain has yet to really return 100% to normal and have a healthy life of its own. But it's 6 to 12 months. Now, if somebody comes in and this is their 6th or 7th episode of depression in the past 10 years, then we're talking about the possibility of staying on these medications for a much longer period of time for prevention purposes. There's not a lot of good research out there on that, and there's more that needs to be done. But there are individuals who do have to make a long-term commitment to the antidepressant if this has been a cyclic type disorder.
But if a person starts taking a medicine, let's say an antidepressant, should they expect that within a day or two they'll feel better, or should they expect that this may take 4 weeks, 8 weeks, 12 weeks?
That's the rub. These agents don't immediately work right away. People think in terms of, well, it raises serotonin, therefore I should be better within a minute because my serotonin level is too low to begin with. Well, that's not really hard science. The bottom line is that most of these disorders are due to an imbalance in the ratio of brain chemicals, not just a quantitative deficiency of serotonin or norepinephrine, which is the other major neurotransmitter, but an imbalance of these neurotransmitters. And it looks like the antidepressants have a delayed effect, that they lead to correction of that imbalance and possibly even other secondary changes after 2 to 4 to 6 weeks. And so staying on a medication is really the goal. And therefore, part of my responsibility, and I know you've helped with in patients that we share together, is helping people stay on medication.
Right.
The good news is that the newer generation of agents compared to the older generation were called the tricyclic antidepressants. They were effective, but they had lots of side effects: dry mouth, constipation, rapid heartbeat, low blood pressure, weight gain, which was a real problem, and that's why it limited the effectiveness of these medicines. And so when the new family came along, Prozac, Zoloft, Lexapro, Celexa, fluvoxamine, Paxil, et cetera, they didn't have the same degree of side effects. So they were much more easily tolerated. So therefore, it was easier to get people to stay on them long enough. Interestingly, there's an antidepressant that we use now as a sleeping medication. Trazodone is the generic name. It's, in fact, no longer made in a brand form. It was Deseril when it first came out. But it came out as an antidepressant in a dosage of 300 to 600 milligrams daily. And it was a financial flop. And it was a financial flop because everybody who took it at that dosage range slept all day long. They were no longer depressed, but the sleeping cure doesn't work very well.
They had a good nap.
And so since, although interestingly, the Japanese had a sleep treatment back in the 80s and 90s, but that's a whole nother story. But so trazodone became an agent we use frequently for sleep at a much lower dose, like 25 to 100 milligrams at night, with very good effect because it's helpful for both instituting sleep and maintaining sleep. But the new generation of antidepressants have less side effects, and so it's easier to stay on it for the 2 to 6 weeks that you need to. The other thing that we learned was that when the tricyclic antidepressants came out, and based upon my gray hair, you can imagine that I was born and bred on those agents back in the day. We used to increase the dosage every week. That's not the case with the new generation of antidepressants. If you do that, people get side effects very quickly. And so the goal is to get somebody up to a therapeutic dosage and then let it percolate for the period of time that's necessary to see if there's a response.
Yeah, my patients who are started on medicines, during the first 2, 4, 6, 8 weeks, a lot of the work that I do with them is to help them understand that this isn't the kind of silver bullet to begin with that you're expecting, but also it's a process of your nervous system not only getting used to it, but starting to experience the benefits of it. So really, just like anything else in life that we do, it's not an overnight cure. Just like if you start going to the gym, it takes weeks and months till you start to feel like, oh, I think I feel stronger, I think I look different. So the process with medicine is really the same as the other types of therapy. If a person is on medicine or isn't and is engaging in what we'll talk about for a few minutes, the cognitive behavior therapy model, with that model, which we use for anxiety and depression and other types of issues, we do have a certain time element to it where we have a certain pace or a certain amount of expectations of movement over, again, usually depending on the problem and the symptom, anywhere from typically 3 months to 5 months before we see significant improvement and even resolution, depending upon what we're targeting. But still, to me, it's like learning a new language. If you were going to start to take a course in a new language, you go through different phases of learning words and then learning how to translate and then letting it sink in more where it becomes part of you, and then at some point become fluent. And so cognitive behavior therapy is a perfect example. It tends to be more structured. It tends to be more where some people feel like it's more educationally oriented or academically oriented because we have workbooks that can feel like lesson plans, but it's very helpful in terms of keeping a person focused from day to day on working on the changes that we need to help them make in their thinking and in their behavior. Instead of in the old days, we would just talk and then the person would kind of go back out there for the next week relying on their old behaviors and their old habits. So cognitive behavior therapy is very structured and it does have a time function to it, usually a few months. There's another type of therapy which isn't so much focused on symptoms. It's the type I was talking about before in terms of a person really wanting to explore themselves, learn more about themselves, the role that they play in their issues in life, and to learn about expectations in life. And that would be more coming under the category of what we call interpersonal psychotherapy. It's not symptom-focused. It's more kind of sitting with another person who has the techniques to be able to explore the person's issues, personality, and life goals. And that's more open-ended. For some people, we have a short-term version of that where sometimes in just a few sessions, they can figure things out that they needed to figure out, and they're off and going. For some people, it's months, and believe it or not, for some people, it's many years. Some people really like the process and they'll choose to stay in it because they find it so helpful. So the variability in terms of the question, how long does one go to a mental health professional for? It's a huge variability. And again, it depends on the type of problem that you're going for.
You know, the benefits I see with cognitive behavioral therapy have a lot to do with the core aspects of any type of emotional change or illness. Just imagine we go through life knowing who we are to some degree, not worrying about sleep, not worrying about appetite, not worrying about a busy head or racing thoughts, and suddenly something changes and you don't feel like you're yourself. That's terribly frightening. One of the beauty that I see of cognitive behavioral therapy is it gives somebody practical techniques to utilize. And it's similar to the person who's terribly out of shape, gets short of breath when they run for a block and decides to go to the gym or get a personal trainer. And they get a number of exercises to work on. They now are in control. And we've talked before about this concept of locus of control, but giving individuals that control, the ability to work on something, I think is half the battle of recovery. And that's where the techniques that individuals can then practice with cognitive behavioral therapy become so valuable because they're back in control again. That's why it's something as simple as somebody with terrible depression who has been housebound and not wanting to talk to anybody. If you can get them to go out for a walk 3 or 4 or 5 days a week, even for 20 or 30 minutes, get them back into some level of control. Because most people, when they get ill like that, feel like the illness is controlling them rather than they're in control of the illness. Not to minimize the impact of the illness, but they feel like they're totally out of control, and that breeds the hopelessness that develops. And so providing individuals a return with something to work on and understanding that they can be in charge of their recovery. And that's where I tell people with medication that this is how the medicine works. It's not going to change your personality, but it should decrease your tendency to be stuck in your head. It should give you more of a sense of wellness, of pleasure. Will take time, but if you hang in there, you will get back to that level of happiness and health and wellness that you want to get back to. Making sure that they also pay attention to the need for psychotherapy if it's indicated at the time.
Yeah, I describe it to my patients as, because of the problems, you've given up a lot of territory that you used to have. And our goal is to recapture the territory that you've lost. Not only that territory, but some new territory. And very often, I'd say we're very, very successful with that, which is why we love to do what we do as two shrinks and a mic.
We wouldn't still be doing it after all these years if people didn't get better. It would be a very unrewarding profession to be in. Thankfully, we've got both the psychotherapeutic techniques and the medications available and a biological and psychological understanding of the disorders now that help us really get people better. So I'm Dr. David Gross, psychiatrist.
And Dr. Andrew Rosen, psychologist. And this has been Two Shrinks and a Mic.
Happy and a healthy new year. Make 2026 a good year.
See you next time. The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.